Good afternoon, everyone. It's a pleasure to see you all here. My name is Molly Mitchell, and I'm with the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome you all here for our June 2012 Public Health Practice Grand Rounds. And today's topic is on reducing asthma disparities in children, a model program with promising results. And before we get started with our two presenters, I just want to make a few announcements about some of our trainings that are coming up. And for those of you who are watching us online, if you would please click on the link for signing in, that'll give us a better count for us to report to our federal funders of how many people we're training today. And also for those watching online, you can also just click at any point on the link on the screen if you have a question for either one of our presenters. That way you can send an email question in for them, and we'll have Q&A at the end of the session. And while you're on our website, you can also look at some of our upcoming trainings, which include public health nursing and achieving outcomes through best process program design and evaluation. And we also have a new course I want to just draw your attention to, Leading Change Through Communication, Strategic Use of Old and New Media. It's taught by faculty at the Hopkins Center for Communications Programs, and it's meant for anyone who's engaged in communication to try to change behavior. It's going to have 4 live talks. There are 10 modules. It's going through July and August, so please, for more information, check that out on our website as well. And so with that, I think I'm going to go ahead and introduce our two presenters today. First, we have Dr. Greg Diet. Dr. Diet is Professor of Medicine and Epidemiology at the Johns Hopkins University School of Medicine, where he is the Director of Clinical Research in the Division of Pulmonary and Critical Care Medicine. Dr. Diet received his undergraduate degree in economics from Wharton School of the University of Pennsylvania, his MD from Temple University, and a master's in epidemiology from the Johns Hopkins Bloomberg School of Public Health. He's a pulmonologist and has a practice devoted to the care of adults with obstructive lung diseases, including asthma and COPD. He has an extensive portfolio of patient-based research in asthma and COPD, supported by the NIH and other sponsors. His current research focuses on identifying factors that cause or provoke asthma, especially air pollutants and allergens that are problematic in inner-city homes. He has also begun examining how dietary patterns may increase susceptibility to inhalable pollutants and allergens. And we also have Kate Scott. Ms. Scott is an asthma program director for the Baltimore City Health Department. She oversees clinical asthma programs, including a CDC-funded translational research grant for asthma home visiting services. She has presented project findings at conferences nationwide and is a frequent resource for agencies seeking to initiate effective asthma programs. She represents the Health Department on the Department of Health and Mental Hygiene Maryland Asthma Control Program Executive Committee and the Greater Baltimore Asthma Alliance. Prior to coming to the Health Department, Ms. Scott was an HIV/AIDS clinic and inpatient nurse at Johns Hopkins Hospital. She started her career in public health serving as a Peace Corps volunteer in Central America and received her RN and MPH from Johns Hopkins. And with that, I'm going to hand the floor over to Dr. Diet. Thank you.
Thanks very much, and thanks for joining us online and here in person. I'm going to go first before Kate to try to give you an idea of some of the work that we've done at Hopkins that sets up the kind of intervention that Kate's working on, and give you an idea of why we've been working together on that. And I'm going to focus on findings that come from our own center, the Center for Childhood Asthma in the Urban Environment. I want to start by telling you about a boy that is in one of our studies. And when we met him, he was 10 years old. He's African American and lives in East Baltimore, which is where Hopkins is located. Household income was low, and he's very symptomatic. So in a 2-week period, he'd had 4 days with symptoms. He'd woken up 2 nights. And in the past 3 months, he'd had 4 unscheduled doctor visits for his asthma. He's on a whole host of medications, and most of the ones that we know to prescribe, albuterol, an inhaled steroid, a leukotriene modifier, and then also systemic steroids. And in his home, he had, among other things, an active smoker, cockroaches, and mice. And so he's in a lot of ways is typical of the people we have in mind for our studies. I'll point out here, this is a graph from the CDC, and the circle is 1998 because that's when he was born. So we met him in 2008, and he was born in the midst of an epidemic that's been increasing and continues to increase beyond the length of this this figure. The figure's split because the CDC changed the questions that they ask in 1998, coincidentally when he was born. But what you can see is both for children and adults that there's been a rise over time and in a relatively short amount of time. What's important also is that we see this is about the same time scale as the prior slide. And one of the things we can see here too, this shows mortality over a time scale. And there's been some attenuation of mortality, which is good over the last several years. But the gap between mortality for whites and blacks has actually increased, even though there's attenuation overall. And this is true for other outcomes too, hospitalizations, symptoms, and other things that are important. So this has been our focus, is to try to identify factors that contribute to this disparity and also to try to eliminate them. And I'm representing a group called the Center for Childhood Asthma in the Urban Environment, which is funded by NIH, the Environmental Health Sciences Branch, and EPA jointly. We're in our third 5-year funding period, so we've had this center for more than 12 years, initially led by Peyton Eggleston and now led by Pat Bricey of School of Public Health and myself from the School of Medicine. This is a model that started the center, and it still guides us now, which is that we're really looking at complex interactions between factors that can bring on asthma or make it worse. We focused on pollutants and allergens, and we focus on ones that originate or congregate inside the house. We look at the steps that lead to immunologic sensitization, that lead to symptoms, and what you see on the bottom there also is that, and for you online, I'll just show you, if I can get this down here, that we don't look at this in a vacuum. We look at it in the context of where people live and how they live, and recognizing that asthma, as with most chronic conditions, is not just the disease, but also related to the susceptibility factors that are contextual. This is a picture of our laboratory. You know, some people have an actual laboratory to study. I don't, and this is what we consider to be our laboratory, which is a picture of a typical block in East Baltimore. And what you can see is that although the housing structure differs from neighborhood to neighborhood, that what's very typical is 2 or 3 story row homes that are turn of the prior century in terms of when they were built, and that there are many that are occupied that are also adjacent to unoccupied houses as well. So I'm going to address just three of the points that I think we make with our center, just to give you some highlights of things that we've worked on that I think set up, I hope, nicely for Kate, the intervention that she's working on. And one finding about whether or not domestic mouse allergen causes asthma morbidity. So do mice in the house make asthma worse? Do the pollutants, particulate matter and nitrogen dioxide, do they make asthma worse? And then the third point is, can we intervene? What's available to do right now? So with this first point about mouse allergen, so that's not a mouse, right? That's a cockroach. And before I talk about mice, I just want to bring us back for a second. We've known more about cockroaches longer than we have about mice in terms of what they do in the house. And it's a story that's been known for a while. This is a poster made by our Community Advisory Board in connection with the Maryland Institute College of Art. And there's a few posters they made, which I think are really nice, but illustrating some factors that affect asthma. The reason I'm showing the cockroach, though, is I just want to explain the working model for what an allergen does and why it makes sense to study it the way we do. So this is a little bit of a complicated slide, but not too bad if you take a moment here. The point I want to make here is that there's 2 steps to becoming a person who's allergic to an allergen. And the first step is illustrated at the top here, where the allergens, which are those little green dots, they come in and they meet certain kinds of white blood cells. Those white blood cells communicate, and you see over on the right-hand side of the slide that B cells, which are a lymphocyte, they put out antibodies as a response. And those antibodies are those little upside-down Y things, the yellow. And they go and attach to other cells, in this case mast cells. Once they've attached, that's now a sensitized cell. So that step has to occur first. First, the cells become sensitized. And then the second step is now you're re-exposed to that allergen, and that causes symptoms. So 2 steps have to occur. First, sensitization, and then second, re-exposure to the allergen. Reason that's important is because this is a cockroach finding, and this is a study that was published over a decade ago from the National Cooperative Intercity Asthma Study. And this showed very convincingly that cockroaches matter in terms of asthma morbidity. So this illustrates hospitalizations in kids with asthma. And there's 4 bars there, and the first 2 blue bars are non-sensitized. So these are kids who have not had that first step of sensitization to cockroach. And the first bar is low exposure, and the second bar is high exposure to cockroach. And you can see they have a similar amount of hospitalization. The next bar is sensitized but not highly exposed, and that also is similar. So they don't have that second condition of high exposure. But when the two are together, there's been both sensitization and exposure. That's when you get the morbidity. So this is sort of the working model for allergen provoking asthma. And it's the same model that we use to look at for mice. So in one of our studies, we recruited preschool-age children, so 2 to 6 years old. They were all in 9 contiguous zip codes in Baltimore City. They had to have healthcare doctor-diagnosed asthma and have active asthma within the last 12 months. We also recruited controls who were very similar, except they didn't have doctor-diagnosed asthma or symptoms. This is a map of Baltimore City, and it's a partial map, but there's some things you can see on here. I'll use the cursor, but this is where we are right now. This is Johns Hopkins Hospital and Johns Hopkins School of Public Health are on this intersection. My cursor disappeared, but this green plus. And you can see that the red dots are people with asthma, and the triangles are controls, people without asthma. And we use this sort of northeast quadrant, if you will, of what's defined as East Baltimore to do our studies. We spent a fair amount of time assessing what their indoor environment was like. So we sampled particulate matter, which I'll talk more about in a little bit. We sampled dust from the bedroom and the kitchen and the family and TV room to look for allergens. We had a home inspection, and we also asked parents or caregivers about the life history of the child in terms of exposures that they might have had. And I'm only going to show just a couple of findings on here that are relevant to mouse. But one is that I thought was very interesting is just in terms of self-reported exposure. There's a lot of awareness of mice. You can see the majority of parents or caregivers said, yes, indeed, we have mouse exposure in our home. It's a higher bar than cockroach. So cockroach is high, and those are both higher than pets. So mice and cockroaches matter a lot. Smoking's on there, too, and it's about 58%, which is remarkable and startling, given that there's the average in the country is about 21% for all comers. So in our city, in homes with asthmatics, we have more than half with a smoker. So one of the things that we assayed from the dust was a protein that comes from mice. It's found in their urine, so anywhere that mice go, you can find this particular protein. And it's thought to be a pheromone-binding protein, so some way to attract a mate. And it's a light enough particle, unlike some, that it can become aerosolized or airborne, so it can float around and be in the breathing zone, whether or not it's in the settled dust or in the air. And what we found was a parallel story to what has already been shown for cockroach, which is this is looking at rescue medication use, so the number of days of medication, 3 particular time points. And the first 2 bars in each of those 3 collections of bars are the non-sensitized kids with low and high exposure. The right-hand 2 are sensitized, low and high. And you can see that the most prominent bar in each case is those that are both sensitized and highly exposed to mouse. And we found this for a variety of symptoms as well. This illustrates using albuterol as a rescue. We also, in a longitudinal model where we looked over time, we could find that unscheduled doctor visits, ED visits, and hospitalizations were all importantly and significantly associated with being both highly exposed and sensitized to mouse. And in this case, the hospitalization odds ratio was nearly 70, meaning it was just a remarkably strong risk factor. And this is after adjustment for other things, including cockroach. So we found this to be a very important finding for us, which is at least in Baltimore City, that there's a lot of mice and that there's a very important impact of them. So this other issue I want to address is whether or not certain pollutants that are inside the home can aggravate asthma. And many of you may be familiar with particulate matter, but in case you're not, I just want to show you that particulate matter is basically dust, and it's dust that's small enough in the case where we study it, small enough to enter the respiratory tract. It can come from natural things, so it's part of just dust that's from dirt and things out in the world. It includes viruses and bacteria, animal debris, and then there's man-made sources too. So mostly from combustion, so trucks, buses, cars, factories, and then inside tobacco smoke and anything that burns produces particulate matter. I want to give you an idea of what particulate matter looks like because you can't really see it up close. We're talking about something that's a tiny fraction of the width of a human hair, so you can't see it up close, but you can see what it looks like from a distance. And this is a slide from a camera that's mounted near Boston, and it shows what the PM 2.5 concentration was in about the 10 range. And it's micrograms per meter cubed, but the thing just to keep in mind as I talk is just that number 10, because I'm going to use the same units in a couple other slides. So that's the skyline when it's 10. This is the skyline when it's about 60. It's a couple days apart, and it's the same vantage point, but what you can see is if you step back from pollution, you can see it better. So remember those numbers 10 and 60. So when we found, this is what we found for in our homes, and this is the distribution of particulate matter in children's bedrooms in East Baltimore. And the first two box and whisker plots here I'll spend most of the time on. This is fine particulate matter, which is what I illustrated in the other the preceding slides. You can see the range here is from 0 to 100, and we've excluded the outliers. So remember, I showed you 10 and 60. The range I'm showing you here goes up to 100, but our outliers go up into the hundreds, so about 300 or so. And what you can see is that the median value for indoor fine PM, that first box and whisker, is about 35 or so. So it's sort of midway between those two slides that I showed you. And what's really remarkable is that that it's much, much higher than the outside air. So if you have an impression about what outside air is in a city like Baltimore, it may not be ideal on most days, but you can see that that red line is the EPA standard in place at the time that we did the study. And because it's a box and whisker, that heavy horizontal bar is the median, the box around it. Let's see if I can make my cursor show you. I can't get the cursor to come on. But the box around it shows the interquartile range. So what you can see is the ambient air would only fail the EPA standard about a quarter of the time. But the homes would fail, if there were such a standard, would fail about 3/4 of the time. So much, much worse inside than outside in terms of particulate matter. Nitrogen dioxide is another pollutant we're interested in, and this is a gas that's produced by combustion. And just a lot of the sources are the same. So if you burn something inside, or if you use natural gas for cooking, or a gas heater, things of that sort will produce it. It also comes from smoke and from exhaust from cars, trucks, and buses. The problem with it is it can damage the airway epithelium. There's evidence that it can increase susceptibility to infections, and it can promote sensitization to allergens as well. So this is another figure I want to show you, and it shows a couple things. So the ambient values of NO2 on the vertical axis, or the y-axis, and indoor NO2 on the x-axis. And two things to notice about this. One is that there is no relationship between the indoor and the outdoor. And this was important for us. This is a swirl of dots that seem to have it's not a straight line, it's a swirl of dots. And I do know that sometimes people will produce a swirl of dots and they'll shoot a line through it and try to convince you there's a relationship. I'm hoping you don't see one. The R² is 0.015, which is really no association. The reason this is important is because you could say that maybe the NO2 you measure inside a home just came in through the window, and some certainly does, but it's not mostly that. There's an indoor contribution that matters. If you look at the range also, the ambient range that we had goes up to 50, and the indoor range goes up to 300. So it's another example of where we actually have a higher pollutant concentration inside than we do outside. So what's the impact? A couple things here. So we looked at it a bunch of different ways and adjusted for a variety of things, but in most of our models we adjusted the indoor for ambient or outdoor values. And what we can find is for most of the common asthma symptoms that there's a significant increase in those symptoms for every 10 micrograms per meter cubed. So remember my slide, the range I showed you was 100. Our actual range goes up to 300, and the difference in the skylines was about a 50-point difference. So for every 10 micrograms per meter cubed, we could find an important and significant increase in symptoms and rescue medication use. And the same story for NO2, and this is after adjustment for particulate matter. So the two contribute in some way separately to the symptoms, and we can find significant symptoms in either case. So the last thing I want to talk about before handing over to Kate is can we intervene? And here, this is an emerging story that we're trying to contribute to. And one of the things I want to mention first is what's already known about this in terms of what the guidelines recommend. So this is a slide that reproduces recommendations for asthma healthcare practitioners from National Heart, Lung, and Blood Institute. And this is consensus and evidence-based guidelines based on what's known. And so we know that for allergens, it says that if a patient has asthma, we should reduce, if possible, exposure to the allergens. But the second bullet point is especially important, that to know that you can't just pick one. You have to have a multimodal intervention for it to work. And the evidence grade is A, which means that there's been a number of randomized controlled trials in the appropriate population to support that evidence. So we know that. That's one thing. And that comes from studies like this. This is one of the NIH-funded multi-site studies that was done, published in 2004, where they targeted allergens and secondhand smoke in a one-year intervention. They dropped cockroach by 70%, the allergen, and also had a drop in dust mite concentration. What I want to show you with the figure, though, which is really important, is that there's here's this vertical bar here that you see at 12 months. That's the end of the intervention time. And so to the left of that dotted line is the year of the intervention, and the blue line is the control group. The intervention group's the orange line. And what you can see is that there's a separation between the lines and a lower number of symptoms in the people in the intervention. So the magnitude of that difference is about the exact same magnitude as what you see in a typical inhaled corticosteroid trial. So medications that we use regularly produce about the same effect as does this intervention. So that's one important point. The other is that unlike medications, the time to the right of that bar is the follow-up year when there was no more intervention, and you can see that the separation remains for the entire year. So it's really a good prolonged effect of an intervention that takes 1 year to put in place, but it has a tail to it, which is quite good. This is multimodal, and it worked. But talking about the irritants in particular, which I think are an issue, tobacco smoke and then the pollutants that I mentioned, the particulate matter and NO2 and some of the others. This is another of the slides from our community advisory board, thinking about tobacco smoke. I want to show you what the guidelines say about these sorts of things. So this, I think, is remarkable each time I see it. So in terms of tobacco, it would seem to be a pretty easy recommendation to say anybody who has asthma, or especially a kid has asthma, don't smoke around them. And it makes good logical sense. But if you look at the evidence grade from the guidelines, it says clinicians should advise persons who have asthma not to smoke or be exposed to environmental tobacco smoke. Evidence grade C, so it only comes from observational studies, not from clinical trials. So it's a pretty weak recommendation for something that I think would have seemed obvious. And then consider referring to smoking cessation, a little better evidence grade, but that's for adults who smoke and have young children. So not the strongest evidence grade for that. Also, in terms of devices that you might think about, these are almost all labeled as opinion-based because there weren't trials to support them. Air conditioning gets an evidence grade C because there's an observational study that showed that people who live in neighborhoods where there are more air conditioners seem to have less asthma. That's the standard of evidence. If you look at the bottom one, air cleaners, which can strain the air of particles and perhaps of gases, they said at the time of the most recent guidelines there's insufficient evidence to recommend them, but they might reduce some allergens. They don't comment on whether they reduce pollutants. So it's a pretty weak standard of evidence. And this one especially makes me wonder where we are in terms of the progress. It says for indoor and outdoor pollution, clinicians should advise patients to avoid, if possible, so not definitely, but if possible, exposure to gas stoves and appliances that are not vented to the outside, fumes from wood-burning appliances or fireplace sprays or strong odors. So there's a sort of lumping together of these exposures that might aggravate asthma, but we don't have strong evidence to say that if you intervene that it's going to work. The guidelines also say, by the way, to come inside when it's polluted outside, and that might not work if you remember the slide I showed a few ago, because there's more pollution of some sorts inside than there is outside. So, what's been done for this? I wanted to highlight some of the findings from my colleagues in the center. This is Peyton Eggleston was the lead investigator on this study, and this was 100 children in Baltimore, randomized controlled trial of 2 groups, and it was again a multimodal intervention where it targeted allergens and pollutants. But there were only 2 things that could have affected particulate matter in this case. One was the use of a HEPA-containing air cleaner, and the other was trying to get people to not smoke. The latter didn't work. People smoked just as much before and after. So the only really thing that happened during the trial was that people had a HEPA air cleaner in the active group. And then the control group was maintained the way they were, but then treated at the end of the year the same way as the active group. And they were followed over time. And so one of the things that Peyton was able to show is that the 2 lines in the lower part show between a 30 and 40% reduction in particulate matter from having an air cleaner in the child's bedroom. And that was sustained. The timeline goes to 6 and 12 months. The control group, it looks like it goes up a little teeny bit, but it's pretty much no change for the most part in the control group. So it showed that an air cleaner intervention as part of a multimodal intervention can reduce particulate matter. And this is the change in the proportion with symptoms, and you can see that there's a good change. Going down is good on this figure, so that in the treatment group symptoms were less, although by the end of a year, the effect was attenuated somewhat. So it wasn't, it was still significant though. And so showing there's some correspondence between PM going down in a multimodal trial and getting better. This is a picture of one of the air cleaners from the study, and I think I like it a lot because it just, I think it's naive to think that the answer to asthma is to go plug an air cleaner in. There's a lot going on in someone's home, and it's not just that, but it can be a valuable contributor to it. Then one other study, which is just very recently completed and reported with Arlene Butts, who's in the School of Nursing as the lead. This was focused on tobacco smoke. This has 3 study groups, and there's a control group which had asthma education, and then 2 that included air cleaners. One was with air cleaners, 2 put in the house, and the other was an air cleaner intervention plus a health coach to see if a coach that goes in to help get people to quit smoking or smoke outside could work as well. And I'll just tell you a couple things about this. One is that the health coach didn't help, so there really was no impact of that, but the air cleaners did work. And this is one figure showing the control group where you see PM 2.5 0.5 concentration, that median bar on the left in the control group is at about 0, meaning that in the ones without air cleaners, their particulate matter stayed about the same. The air cleaner groups, though, it did go down, and it went down significantly and importantly. And I'll show you the actual numbers on that on this slide. So if we look at this, there's baseline and then follow-up and then difference here. But this value here, 3.5, the PM 2.5 went up by 3.5 micrograms per meter cubed in the control group, and it went down by about 20 and 16 in the 2 air cleaner groups, which was statistically significant. So 20 micrograms per meter cubed is an important difference. And this is coarse particles in the lower part of the table, and that also there was an important difference. One thing I do want to point out here is if we look at air nicotine, I can't get this cursor to work over, but in the control group, the difference is minus 0.4 micrograms per meter cubed, air cleaner minus 0.3, air cleaner and health coach minus 0.6, not statistically significant. So meaning that although we could reduce particles, we couldn't necessarily reduce everything that comes from tobacco smoke. So I think the important message here is if there's a parent of a child with asthma, getting an air cleaner could well be good. Symptom days improved in this trial in the people who got the air cleaners, but it's not as good as not smoking, and so it's not a substitute for not smoking. It's sort of the best intermediate thing you could do if you can't get the parent to quit smoking. One last one I'm going to show you is just another approach that we're taking, and something that we've called the stove study. My colleague Nadia Hansel's running this. This is a HUD-funded study, and this we're looking to see if we can target NO2 in particular. It turns out that gas stoves in Baltimore City are very common. They're almost never vented to the outside, so they produce the fumes and particles in the home. And so we have a trial going on right now that where we're looking at homes with an unvented gas stove, and they're being randomly assigned to get a substitute stove, which is an electric stove, or put in a vent that vents the gases outside, or to use 2 air cleaners. And the study will finish December, so I don't have the final results yet. But it looks like, at least for the 1 week, the immediate effect is that that swapping the stove out makes good sense. It's source control, but there might be an advantage to the air purifiers because that also might mop up NO2 that isn't just produced by the gas stove, but from other sources as well. Those aren't final results yet, but it's sort of the early peek at what happens immediately. So these are approaches we're taking to sort of thinking about interventions and ways to improve the environment. So I'm going to finish there. I think we do questions, which I hope you'll send in if you're online after Kate goes. And so I'm going to turn this over to Kate.
You said it was F5? Yeah. Shift F5. Okay, thank you. All right. Thank you, everyone. I really appreciate this opportunity to tell you a bit about our Reducing Asthma Disparities program. We call it RAD. It's an asthma home visiting program that we started in 2008. And so there's 3 things that I really hope that you get out of today's presentation. The first one is that asthma home visiting programs, like the one I'm about to describe, can make a difference in childhood asthma. The second is that this program is based in sound science and good asthma management. And finally, I hope to persuade and encourage you to follow in this endeavor and that you too could have an asthma home visiting program in your community. I would like to acknowledge that this project was funded by the CDC, and again, we started in 2008. The Department of Health and Mental Hygiene was our IRB. We had 2 principal investigators, and we had 5 co-investigators, each of who brought a set of skills and experience that made this program successful. So let's talk a little bit about asthma prevalence in Baltimore. All right. So as you can see on the slide here, 20% of children in Baltimore have asthma. This is current prevalence. This is much higher than the Maryland and the national rate. Okay, let's take a look at ED visits then. So when we compare it to Maryland ED visits, we see that Baltimore City children are going to the ED 2.5 times more frequently than statewide. You look at asthma hospitalizations, you see something very similar, is that Baltimore City kids are being hospitalized for asthma more frequently than our state counterparts. Okay. Now, these two indicators are really important to look at, ED rates and hospitalizations due to asthma, because it's a sign that a child's asthma is not well controlled. Okay. So as you can see on this slide, Baltimore City is not unique to the rest of the state. But what's alarming is the disparity between blacks and whites when it comes to urgent care visits. So if you look closely at the far right, you'll see Baltimore City, and you'll see the number of African Americans, the rate, and how much higher that is compared to whites. Okay. We know there's something going on. So what other disparities exist in Baltimore that can have an impact on asthma? Children living in poverty. This is an astounding number. 37.3% of Baltimore children actually live in poverty. That is much higher than the Maryland rate and higher than the US rate. Adult smoking rates. We just heard from Dr. Diet that smoking can have an impact on asthma. And so what's going on in Baltimore? This survey showed that adults in Baltimore, 28% of them smoke. But what's even more alarming is when you look at household income. When you see that a family earns less than $15,000 a year, that goes up to 36%. And that will become significant when you look at our RAD study results. Housing statistics. All right, let's talk about mice. Dr. Diet did. We know that it's important. It is an asthma trigger. So nationally, it doesn't look like it's that much of a problem. We got 6.3%. Let's take a look at Baltimore. We're looking at 34% on average. Median age of housing stock. In Baltimore, we realize that we live in an older city, and the average age of a home is from 1947. So you wonder why this is important. The reason why this is important is because in older homes, it's more likely to have leaks, drips, entry points for pests, and make it hard to maintain. When you compare this to the national age, it's around 1974. Okay. So to address asthma disparities in Baltimore, what did we decide to do? We went for funding. We received funding through the CDC Translational Research Grant, and we decided to translate the work of Seattle-King County's asthma home visiting program. It's an evidence-based program. Like Seattle, we focused on reducing home environmental triggers and asthma medical case management. Now, when we started, we thought that we would spend most of our time on the home environment and working with triggers and families. But what we found that was equally important was the amount of time we spent with families to go over medication, understanding the difference between a controller and a rescue med, having medications that are up to date, understanding when to take them, how to take them, asthma action plans, and follow-up appointments. Our target population. Children with moderate to severe asthma. Okay, how did we determine this? So this was determined by a questionnaire that was completed by study staff prior to enrollment. Those questions included symptomology in the last 2 weeks, so looking at daytime, nighttime, rescue medication use. We also asked about ED visits and hospitalizations in the last year. And we chose children between the ages of 4 and 18 who are Baltimore City Public School students. So one of the most important aspects to making this program a success were the partnerships that we developed while we set up RAD and while we were running RAD. So in the health department, we know that we're good at certain things, right? So we're good at community organizing. We're involved in the community. We know the resources that are available. We're tapped into internal and external groups that can help families in need. But where we needed strengthening was in our partnerships and our clinical expertise. So we reached out to our asthma clinicians here at Hopkins. We had allergists, pulmonologists, and general pediatricians who were working in the trenches with families of children with asthma. And that made a huge impact on the direction that we went. Asthma champions also able to share information with us in the community about their own experiences so that we could learn from that, but that they could also advertise and promote our program. Area hospitals and universities, okay? Where this came into play was that with the backing of Hopkins and University of Maryland, what we were able to do was it gave us the credibility and the ability to do research, which otherwise might have been more challenging. And we also wanted to coordinate with area resources. So the Greater Baltimore Asthma Alliance, otherwise known as GABA, that's an asthma advocacy group locally here. And they spend their time with asthma education and disseminating information. So what we did is that throughout the study period, we would go back to GABA and we would ask for feedback. We'd share with them our findings, some of our challenges, some of our successes, and ask for feedback. Because not only was this a study, but it really was a program, an implementation of science, and that we really wanted to have a good service for children in Baltimore. And finally, local area researchers. So we knew other people in Baltimore were doing asthma home visiting studies. So we wanted to make sure that we weren't soliciting participants from other studies, and we wanted to share information. So what were the goals? We wanted to decrease asthma morbidity, asthma symptom days, use of urgent health services, and exposure to asthma triggers. We also wanted to increase provider knowledge of the home environment and communication with families. So what did we do? So this was a 6 home visit intervention over 6 months with a 1-year follow-up. And in between the 6 months and the 1 year, we had follow-up phone calls that the community health worker did. So many topics were covered in each of those home visits, but highlights is what I've included here. Medication and technique, identification of asthma triggers, trigger reduction education, and coordination with providers. So what did we use for our data collection? All right. So what we did is we collected data at the beginning of the study and then at the very end 1 year later. We used 2 instruments. The first one was a baseline interview. It was an extensive form, and it was about the medical management of a child with asthma. So it included symptomology, ER visits, hospitalization, episodes, asthma action plans, caregiver quality of life, medications, medication technique, allergy testing, you name it, it was in there. Very comprehensive form. And then the second instrument we used was the home environmental assessment. So this was key to the program because the community health worker at this point would do a walkthrough with the family. And what they would do is they would walk through the living room, the kitchen, the bedroom, the bathroom, and the basement if there was one. Okay? They do it with the families, looking for asthma triggers, opening up cabinets, looking for holes between pipes, where pests can move in and out, looking for evidence of mice and roaches, which are extensive in Baltimore City housing in this study that we found. And also to educate families. And what happened is that based on this baseline and this home environmental assessment, that really geared the direction of the education that the family received. So the final piece was the encounter form. So this was a 2 or 3 page document that went to the medical provider or providers of the child, of the child that we were seeing. And what that did is that it was kind of this little snapshot of what a community health worker did in the home, which was really nice because we looked at symptomology, daytime, nighttime, rescue medication use. We looked at medication technique and what meds were in the home. We looked at ER visits, hospitalizations. We also recorded what we had discussed, our protocols, our problems that we identified in the home. And those problems include everything from med adherence, med technique, mice, roaches, smoking, etc. Okay. So we also did goals. So the community health worker sat down with the family and said, okay, hey, we got this, all these things that we can work on. What do you want to do first? Okay. Set tiny goals so that when they come back, they have some success. And if they didn't meet those goals, then talk about why and try and come up with new goals. It also included date and time for the next visit. So the beauty in this tiny form is that it went to the medical provider, and often we got feedback from the medical provider that included things like, I had no idea there was a mouse infestation, I need to add this to the regimen. Or, I haven't seen this child in 2 years. Very helpful. We would go back then to that family and say, okay, is there another provider that your child is seeing? If not, let's make a follow-up appointment. Okay. So what did our baseline data look like? So we're looking at 102 kids. The majority are African American, mostly boys. Average age around 9. Family size about 4. About 2 people in the household had asthma. And significantly, looking at this, almost 97% of the kids were Medicaid. So we didn't select for Medicaid kids or low income, but it's just kind of what happened. So this mirrors a little bit of what Greg was reporting in his studies, that on this initial assessment, this is what we found, that almost 59% of families had mice, 42% had roaches, 38% had a furry pet, and that 31% of the primary caregivers smoked. Okay. So after the intervention, pre-post data is what we're looking at now. So what were the reported changes in the child's health? Okay. This is over a 2-week period. So we saw a decrease in symptoms, decrease in nights awakened, a decrease with having to stop their play, a decrease in rescue medication use, and happily an increase in controller meds. Okay, what else did we see? Well, so at that initial visit, we asked about hospitalizations. How many times had that child been hospitalized? So out of our study participants, they'd said that a child had been hospitalized 44 times. Okay? At 1 year, it was 32. 12, not a big difference, right? Until you look at the cost of an average hospitalization in Baltimore City. So the average cost is around $7,900, and depending on the institution that they go to, it can be higher or lower. So that number will become important in the next slide. The other is the number of ED visits. So pre-intervention, 240 ED visits is what families had reported. So then when you looked at it 1 year later, it's still a high number, 139, but it's 101 fewer. So if an average ED visit in Baltimore is $772, that begins to add up. Okay? And the mean number of ED visits in the past year actually did decrease. That was significant. Okay. Cost averted. So we look at the hospitalization and ED visits, and that total cost is around $172,000. So we're looking at almost $1,700 per child is what they're costing the system. Home visiting program costs, about $141,000. And you're wondering, okay, what does that include? It includes the community health workers, nursing supervision, a referral coordinator that I'm going to talk about soon, and supplies. And those supplies included mattress and pillow encasements, pest management supplies like baits, gels, copper mesh to plug holes. It also included a mop, a bucket, and green cleaning supplies like baking soda, Bonami, vinegar, so non-toxic, and a vacuum cleaner. Okay, so the average cost for a child in the program was about $1,400. So the difference is around $304. That's the potential cost savings. All right. So how does this compare to our counterparts who we were translating the research from, Seattle, King County? All right, their program costs are similar, about the same, $1,300. Now their direct medical cost averted is a little less, $124 to $147 compared to RAD. But there's some subtleties here in this slide that I'd like to point out. The first is that Seattle, King County, their data is coming from 2001, 2002 cost data, versus ours, we're looking at Medicaid cost data from 2011. Okay. The other is that the RAD data is self-report. Okay. And in Seattle, King County, they had medical records. And so what we're doing now is that we're actually examining our Medicaid kids and we're looking at Medicaid claims data, and we're doing a pre-post intervention analysis to determine if our self-report data does actually mirror the actual cost data. Lessons learned, infrastructure. So if you're going to undertake this, know your institution's strengths and identify where you need assistance. So like I said earlier, the health department, great with partners, great with community, and they know the resources, right? And also we have a very holistic approach to working with families. So we have a community health worker model. So for example, if Brandy, one of our community health workers, goes in to see a family and mom is stressed out and she's all worried about her gas and electric being cut off. So the first thing that she's going to do is not to be talking about asthma and how many days the child has had symptoms and did they sleep well last night. She's going to pull out her resource book and said, have you called blah, blah, blah? Have you called this resource? Okay. Is your phone working? All right, let's use mine. Actually connect that family to those resources right then and there. And then that provides that gateway, that entry point, and also that confidence in this person who's now entered their home to say, hey, they're here to help me. Okay. Program database. So we didn't have one when we started. It took about 6 months to get something up that was just a skeleton. It took a year for us to get something that really we could pull information out of, that we could look for loss to follow-up, overdue visits, etc., run reports on the community health workers and their caseloads. So just knowing what your strengths are and knowing where you need to build in more time is important. Staffing. I'm a firm believer in the community health worker model. I feel like they have this unique connection with families in Baltimore that they're able to communicate important information in a way that families understand. And the beauty of this is that we have a nurse manager who is the support for the community health worker. And so that encounter form that I was talking about, that the community health worker fills out, that actually goes to the nurse manager, every encounter form. She reviews it, sends back feedback to the community health worker and says, what about this? Fix this, da-da-da-da-da. The community health worker fixes it and then sends it off to the physicians. Referral coordinator. So what's the referral coordinator? So basically, we currently get between 40 and 60 referrals on a weekly basis, especially in the high season for asthma in the spring and the fall. So we found out early on that we needed referrals to be funneled through one person. So this referral coordinator, she gets every referral that comes into the program. She enters it into the database. She screens every call. So that means that she completes the questionnaire to determine eligibility. And then she assigns the case to a community health worker, makes the chart, puts it on the calendar of the community health worker, sends out a letter to the family, etc. Extremely important part of the program for us. And the other is to recognize the training that's involved when you are working with staff. So you make sure you have to build in the time for it. And that what we did here is that we looked at our asthma partners, and we had the community health workers actually go into the clinic setting where they could observe clinicians working with families with children with asthma, so they could kind of see and learn a little bit more about what happened in that kind of exchange. And it also gave us the opportunity for the clinicians to get to know us a little bit. Okay, so that is Brandy, or that is Tyra, who, I've just spent the day with, and she's going to be sending me, encounter forms on this kid. So it's always nice to put a name with a face. The asthma training was extensive, and it's something that's always ongoing. So it's not just that one-time thing. It's the weekly meetings that the nurse manager has with her staff. It's the monthly updates that are a little bit more in-depth, that make sure that the community health worker is confident in their knowledge and how they're presenting this to families. Healthy homes. So we know that the environment where we live, where we work, where we play, has a huge impact on our health. So what we did is we used the National Center for Healthy Housing, and the community health workers and staff actually took the Healthy Homes Practitioner course. It was a multi-day course, and then they did refreshers. And one of the nice things is that in-house we actually had an IPM expert. So For those who don't know, IPM stands for Integrative Pest Management. So it's a green way of managing pests. A very important part when you're looking at a healthy home. So we did a lot of internal training also to refresh and so that the community health workers were comfortable when they were actually looking in the home and looking for asthma triggers. And finally, we used motivational interviewing. So we had an expert come in, do multiple trainings with the community health workers and the staff because the community health worker already has this really nice relationship with the family. But sometimes you need just a little bit more knowledge to identify where a family is in the stages of change. And so when you're able to do that and you know where a family is and you know kind of how to target your teaching, and that's what the motivational interviewing did. Other lessons learned, referrals. Initially, we thought we were only going to be getting them from school health. We had planned on that because we were thinking that those would be the children that were not in a medical home. What we found was that when our IRB finally came through, it was in late spring, and so school was almost out. We had a ton of referrals from school health, but we knew that summer was coming and we needed to branch out. So we went to our clinicians, we went to area hospitals and EDs. And as a result of that and the partnerships that developed, we were integrated into 2 systems. And so in those 2 systems, we now get weekly updates from one of them, and the other, it's built into their electronic medical record, so that when a physician is seeing a child for asthma, not only are they checking, did I give the child an inhaled corticosteroid, have I sent them for allergy testing, what was their ACT test score, and they can also check for home visiting. Okay? So what that does is that makes it easy on the clinician and makes it easy on us because we get the referrals and then we can act on them quickly. What we also found was that the ratio of number of referrals to actually kids enrolled was about a 1-to-5 ratio. It varied a little bit depending on where the referral was coming from, but about a 1-to-5. And I talked to some other area researchers here in Baltimore, and they said that they'd found the same, so it was about right. And then the partnerships and coordination of care. So that clinician buy-in, extremely important. So what we did is in some of the clinics in the area, we did like brown bag lunches or early morning breakfasts, and we tagged on to their monthly meeting and basically kind of said, this is what we're doing, this is our program, this is how we hope to be helpful to you, this is how you do a referral. Okay? Asthma Champions became a huge kind of advocate for us, and that included school health nurses and actually local and state government, and then database management. So what we did was that we got our database up and running, but then for our baseline and 1-year data, we moved that with the program evaluator to the University of Maryland, where she could actually analyzing it using statistical modeling and all that fancy, statistics to show our results, which was very helpful. So conclusions. So going back to the beginning, I was hoping that you would see that asthma home visiting programs can make a difference in childhood asthma. So in this study/program, we saw that we decreased triggers and symptoms, decreased ED visits and hospitalizations, and increased med adherence. There was a cost savings, about $304 per child. And that the most important part is that this actually confirms the other research that's already out there, that asthma home visiting programs work, and they should be incorporated into comprehensive asthma management. Greg's slides showed it. Seattle showed it. I was recently in Chicago, and they also had the same CDC grant. They have very similar results. So it's time now to move the research into practice and to have these kinds of programs integrated. And that's it. Thank you.
Great. Thank you so much, Ms. Scott and Dr. Diet. At this time, we do have time for questions, both from the live audience here and from those of you who are watching online. for both of our presenters. Again, if you're watching online, just simply click on that link on your screen and you can send in a question to either one of our presenters. And if you're here in our live audience and you have a question, if you could just please wait for the microphone to come around, and that way everybody who's watching online can benefit from your question as well. So with that, we can get started with questions. Yeah, right here.
Hello. So it sounds like you guys have integrated IPM as part of the asthma management. My question is there data showing specifically that the pesticides are contributing to symptom severity or symptom frequency and or the development of asthma in kids who don't have it?
Yeah, it's a great question. And do I need to repeat it for people online, or?
No, because she had the mic. So.
You had the mic. Okay, great. There's a lot of great questions in that one question. So one is whether or not pesticides contribute. And the other is, what should the components of integrative pest management be? And I think the second one's easier, to handle in terms of, whether you think about a pesticide-free approach to it or not. I think the better programs include bait and then elimination of pests that way. And that even within the use of baits, that there are better and worse approaches, I think. I'll just give you an example. That the NIEHS conducted a study looking at cockroaches, and they compared an entomologist, so a bug expert-driven approach, to hiring the companies that are pest management companies. And what they found was that there was actually a very good logical approach, which was to put these baits along the places where entomologists see the trails. So they look for the trails for the cockroaches, and then monitor what happens. So put in new baits after they've been eliminated to see if they've come back, and use the monitoring program to then decide when you need to sort of redo your program. The professional companies so far, what they tend to do is spray in spots that just happen to be maybe typical, like corners or holes or things of that sort, but not literally driven by where the critters are seen. And then they also come back on a schedule, but a time schedule, not based on what the results are. So they might come back in 6 months or a year or something. So even within that, there's a good approach. I think the ones that don't spray insecticides are better because of the concern that you bring up, which is whether or not they can provoke asthma. And virtually any spray of any sort, whether it's an insecticide or a cleaner or something else, can provoke an asthma attack in an asthmatic. So I think the ones that don't involve sprays are the better approach.
And just to add on to that, when we started, I had to actually sell the community health workers on integrative pest management. They were more in tune with using the RAD sprays. One even had told me about using antifreeze on a cotton ball, and that would kill mice. So when we started, I was like, all right, that's one way to do it. But when we're working with our families, we're going to use IPM. All right? And they followed along with me. They're like, okay, Kate, yes, we're going to do it. But it wasn't until they actually implemented it in the home setting where they saw the improvements, especially with the roaches, and they would come back 2 weeks later and it would be a significant change, that they were sold on it. And so they became really good advocates for this type of an intervention, which also helped with buy-in for the family too, because they saw an immediate improvement.
I have a question. When there is in the natural history of asthma is towards an improvement as the kid gets older, how can we tell that there are improvements or quantify the magnitude of the benefit of this intervention? That is, how can we say that it's because of the intervention versus it's, the kid is improving? And do we have any case control study, or because the before and after probably, it's a little bit more difficult to make those assumptions in.
Well, I know you can answer it really well too.
Well, yeah, it's a great question, right? I mean, it's an issue of study design and what standard of evidence you need in order to guide what you're going to do. And I think that part of the reason that we presented together is that I was presenting more clinical trials evidence that had a control group. And the good thing about clinical trials is that by having a control group is you can be confident that the signal you see is from the intervention. The bad thing is that we highly select the people to get the intervention, and it also doesn't prove that you can just roll it out in the community. So I think the two kinds of research are complementary. I think you have to do NIH-style controlled trials to prove that an intervention can work, but that's not really feasible on a mass scale. And to ask a city, or a state or a country, to roll it out in a controlled way is difficult. So I think some of it's program evaluation after having proven that an intervention can work in certain circumstances. I mean, your point's a great one.
Following up on that, but I think also when she's doing the Medicaid analysis, when you're actually getting the real cost data, at that point she could go ahead and find match controls in the community. That's one thing we've done.
And that's exactly what we plan on doing. Yeah, that we'll have a match control group. Yes.
Yeah, right down here.
Kate, you mentioned that now that you have data from Baltimore as well as Seattle, what are your thoughts in terms of moving these studies into a research to practice mode?
So I'm more than ready to move this into practice, and I can see it in a variety of settings. So I can see it in the health department, and there's positives to that. I can also see it based out of a patient-centered medical home, so where a child is already being seen. And there's a possibility that you might actually see a greater improvement in asthma management when they're locked into a medical home, possibly. But I could see it in both settings. And I think that with the Affordable Care Act, if it moves forward like we hope it does, that you'll see more of these preventative services in place, as I hope.
I just want to follow up too, if I could, because I think that's it's a great point, which is the what to do next. And I think part of it's a matter of people who care about the issue to try to articulate some of the cost and benefit issues of the programs as well. The slide that I showed that was done by the NICA study, where there was a 1-year follow-up period showing that it still worked even after the intervention was gone, is enormously important because we accept, without even thinking that hard, that it's okay to use asthma medications that have a temporary effect. And we pay hundreds of dollars per month for each medication, and that's a no-brainer. We just do it. But then when we talk about a program that might average over a year, $100 a month, people get excited. They say, well, that's an expensive thing. How are you going to sustain it? And so I think, making some case that, costs are worth it in some cases. The other is that, medications, for example, have side effects. Most, but not all, of the interventions that target the environment don't really have side effects. Getting somebody to quit smoking, doesn't cause health problems for the most part for the child, if the parent's smoking around them. Air cleaners use a little bit of electricity, but they don't harm you. And so there's other ways to think about the trade-offs too, in terms of costs and benefits that I think we all collectively have to articulate to the people who are in charge of allocating dollars for healthcare.
Okay.
I had a couple of questions. One, the data on your smoking counselor were not significant in terms of the effectiveness of that, and I'm wondering if there are alternatives that you might recommend, for programs that might be implemented in other cities. And then the second question, your interventions were focused on children who had severe asthma, moderate to severe asthma. And yet the guidelines recommend that these kinds of interventions be considered for all asthmatic children. So I'm wondering if you have plans to expand the intervention for all asthmatic children.
So the second part first maybe, so about where you should go with it. I think that the guidelines are a little soft in terms of the recommendations about who should get the interventions. And I highlighted in a couple cases where they'll say if possible, for example. It doesn't designate a severity level, but it's kind of a soft prompt as opposed to saying that all asthmatics of all types should get these interventions. There's a feasibility part that's implied there. In terms of even allergen reduction, the guidelines say that for people whose asthma is at least at the persistent level, that they should have allergen testing done, allergy testing done through either blood or skin tests. And so there's a little hesitation, I feel, in the guidelines in terms of who should get it. From a trial standpoint, there's an issue of who do you select for a trial, and I think the people who are sicker to begin with have a better chance of showing a signal, and so that's the place to start in some cases, and then see if you can replicate that same magnitude of benefit in somebody who's not as sick to begin with. The study that I showed of Peyton's, Peyton Eggleston's was the first of those air cleaner studies, not the one that had the health coach, and his actually was at the mild range. So his were not very symptomatic to begin with. The second one was a little sicker, and that was deliberate in order to try to be able to find a signal. As far as the health coach goes, we're talking about cigarette smoking, so there's a massive literature on what it takes to get people to quit smoking. And it's partially successful, right? There's evidence for counseling working, there's evidence for pharmacology working, and the two together working even better yet. This particular model was built around the notion that if you could have a smoke-free home and enforce that, what would that look like? And this was one more trial where I think, we found that smoking behavior is very stubborn, and that it's very hard to get people to change their smoking behavior. So I honestly don't know what to do. I mean, it's not enough just to tell somebody that you might be harming your child. It's not enough to tell them to smoke outside, because we know that the smoke comes back in if somebody's on the porch, for example. So it's very hard. I don't know the answer. This particular trial only showed that that an air cleaner could contribute, although not be a complete solution.
Okay, well, we do have some questions from our audience online, so I want to take a minute to take some of those questions right now. And this first one comes from Tiffany, who works in a Head Start program. She says, I work with families of preschool-aged children, and asthma is an increasing problem for our families and young children. What would be your recommendations for how I can use this information learned in this training to help our families?
So, at least in Baltimore, we've spent some time actually trying to reach out to Head Starts, so that we do it in two ways. We offer education at the actual site. So we'll work with the workers, people that actually work at Head Starts, and we'll provide education to parents, so we can do group education classes to share insight. We also have a smaller asthma home visiting program that has that's not a study, but it's mirrored after RAD, and it's smaller. It's 3 home visits. Community health worker model with nursing supervision, and that actually does see children age 2 to 18, and so that Head Start kids are actually can enroll.
Okay. This other question it's really 2 questions. We're now in the 2nd generation of children since these home efforts began. And have you considered addressing the prevention of asthma and allergies through breastfeeding or provided by breastfeeding? And then also, part 2 is, does inconsistent medical care affect asthma management? Why does the Maryland Breathmobile see patients who are already seeing a consistent medical provider at Johns Hopkins?
Well, those are very different questions. So the first one about asthma prevention is a very important topic, and one a lot of us who work in asthma think hard about. And there have been NIH and other federal agencies that have convened groups of people to try to figure out where or if there is low-hanging fruit in terms of prevention. There really isn't a leading major single target, for reduction of incident asthma. And there are different attempts that are going on. For example, there's a study looking at vitamin D supplementation in pregnant moms to see if the children who are born will be less likely to wheeze and then eventually be diagnosed with asthma. That's one approach. There's people who are thinking about the microbiome and whether or not the gut bacteria of children, if it's manipulated on purpose by a supplement of some sort, or through other strategies like preferring vaginal over C-section birth, where the flora that the child gets are different in that case. There's a lot of different potential strategies, but at the moment there isn't a single way to prevent it, and there's not a single best candidate, I don't think, for prevention. breastfeeding, is a big issue. There are observational studies that seem to show an advantage, and some that don't. I think in terms of at least asthma health or allergy. I think the evidence is tilted definitely in favor of there being a protective effect. Trials, I don't work in that particular realm, so I don't know. But trials seem a little daunting to me. I mean, thinking about the idea of assigning someone to breastfeed or not would be difficult. But I don't do that sort of work. Maybe somebody's got a good idea how to do it. But a lot of this gets driven by randomized controlled trial evidence on what to do, not just what might make sense or what an observation might have shown. Do you familiar with the breathmobile?
So one thing is that what we did find is that coordination of care was extremely important when managing children with asthma. And so there were times when you saw that a child was seeing a specialist and also a primary care. I'm not sure exactly the question that the person presents online, because the breathmobile, when I think of them, it is a specialty clinic for children. It's a clinic on wheels. It's mostly stationed at schools throughout the school year, and that's staffed by NP pulmonologists or NPs with background in pulmonology. So depending on who they see at Hopkins, they could be seeing just a general, pediatric doctor, or they could be seeing a specialist. But the point of the RAD home visiting program is that when we worked with the families and we tried to really find out, okay, who else does your child see for medical care? And so when that encounter form was faxed to providers, it actually has all the physicians on the cover sheet. So it's going to have breathmobile, it's going to have Mercy Medical. If the kid is seeing 2 different people, if they're seeing a GI specialist, it also goes to them. So we're trying to kind of break through that barrier and coordinate care.
Here's another one. What does the state Medicaid program think about funding the program in the future?
So we had the opportunity to do a small presentation to the state a couple months ago. They were really interested in our program results and suggested that we move forward with the economic evaluation of the RAD Medicaid claims data, while at the same time moving forward on they have something called an innovation website, and so that they'll feature programs that are up and running, and so that you can disseminate information to others. Because the whole point there's many points to RAD. One of them is to improve children's health, but it's also to share what we've learned with others. So we want to be able to do that. And with that, we hope it will open more doors to actually work with managed care organizations who have a vested interest in lowering their costs for children who use urgent care services such as EDs and hospitals.
Okay. Yeah, right over here.
On the evaluation of the air cleaner, are you able to look at the lasting benefit based on the behavioral change of the parent who presumably has to turn it on and use it? Can you distinguish between well-used air cleaners and ones that are not being used? And secondly, is it strong enough evidence of its effectiveness to entrust the insurance companies?
So a couple things. I mean, in Peyton Eggleston's study, the air cleaners, 50% of the air cleaners were on 50% of the time. So it actually was not anywhere near close to 100% of the time. And so those figures I showed you, though, aren't selected for the people who used it more or used it at all. So that's despite non-adherence, if you will. So I don't know. That was an intention to treat design, and I don't think he broke it out by looking at people who did or didn't use it very well. But it allowed for some non-adherence. You could wonder if people who adhere to something do other things better as well. And so I think that's a fair point. But I don't know how to address that from that trial. In terms of whether people should be incented to pay for these things, I think that's an important issue. if we look at things, if we think there's a carcinogen in the drinking water, I know a lot of people get together and they yell about it and argue about whether to take it out, but we don't insist that there be a randomized control trial that shows if you take it out of the drinking water that a community doesn't get cancer. We just say it's a carcinogen, it's in there, and if we know a way to get it out, we should do it. I think, there's an abundance of evidence that particulate matter and nitrogen dioxide, as just two examples of pollutants, harm people with respiratory disease. And so, I don't think we necessarily need to insist on the same level of evidence that we do to bring a drug to market to say that, something that's logical, that does in fact reduce the pollutant that we know is harmful, ought to be used. And so I think we're at a point where we have enough evidence to say, gee, these things aren't that expensive. They cost hundreds of dollars. They don't have a lot in terms of maintenance. They use electricity at the rate of about a 60-watt bulb. And so we're not talking about something that's over the top expensive that actually doesn't wear out very fast either, and that there is clinical trials evidence of efficacy in both reducing pollutants and improving symptoms. So I think we're at the point where people should want to do this and, spend several $100s, which might be 2 months worth of medication equivalent, on one more thing that doesn't harm people either.
I have a question. How do we decide an optimal number of visits? And do you think that more visits mean better results, or the opposite? That could affect the cost effectiveness of the intervention.
Yes, so we actually want to look at that because we know that a 6-home visiting model is expensive, it's time consuming. You need a lot of admin support to continue to follow up with families. And part of our Medicaid claims data analysis is actually going to look at where did we get the biggest bang for the buck? And so, was it at 4 visits when we really saw adherence kick in and ED visits and hospitalizations drop? I have a feeling it's going to be somewhere between 3 and 4. And I know that other asthma home visiting programs have not always using a 6-home visiting model anymore. They've dropped that number somewhere between 4 and 5, depending on the program. So I expect that we'll change somewhat. We'll learn from the data.
Okay, we do have a couple more comments and questions online. One is whether the Baltimore City Sanitation Department plays a role in cleaning up communities to minimize rodents, if they've been involved at all.
So we didn't coordinate services directly with DPW, but there are services in the city that are related to trash removal and rat rub out. So, but we didn't directly coordinate with them.
Okay. And this is a comment from an asthma and allergy sinus center. The cost savings are impressive. I just want to comment that I'm confident that longitudinally the cost savings would be even greater as the families become more comfortable with the use of daily controller medications, develop greater trust and bonds with their healthcare providers, and ultimately more appropriate utilization of healthcare resources, seeing PCP/specialists in outpatient setting versus ED visits. I find that often it is trust in the system and personal comfort with their understanding of asthma, in addition to better symptom recognition, that leads to better medication compliance and use of daily controller meds. Education is key. So, did we have another question in the back?
Kind of a larger contextual issue. I know you're working in a specific and very important field. What I'm concerned about is that we have, particularly among the socioeconomically deprived communities, other epidemics of diabetes and obesity. And I'm wondering if there's anybody in public health or related fields who's taking a look at whether or not there's any connection between what you're doing and these other epidemics which are plaguing these communities at a great human cost and social costs.
Yeah, it's a great question. Our current center, the third iteration of our Center for Childhood Asthma in the Urban Environment, is actually funded to look at dietary issues and dietary issues as the role that they play in developing allergy and asthma. And it's for reasons that you say. There's a concordance of epidemics in populations of people like we're studying, so like African Americans in the inner city, that diabetes is higher, obesity is higher, and the time trends are very temptingly overlapping, so that the obesity epidemic took off at about the same point when the asthma epidemic took off, and where there's a change in the inflection point of the epidemic curves. And what we're looking at least in our center, is how the composition of diet has changed over time, and how that composition may both provoke allergy and asthma and also fail to protect against it. So with the general notion that there's a pro-inflammatory component to diet, with things especially like processed meats and foods of that sort, and a lack of antioxidant capacity through less fruit and vegetable, less fatty fish and things of that sort. So we're taking both an observational and an experimental approach to looking to see if we can change the trajectory of asthma and allergy with things like diet. I think they're all intertwined, and I think that they're hard to separate, but it's really where there's a lot of value. It's not just one factor.
Okay.
I'd just like to comment on that, because I think what Kate was saying before about also offering other resources to families is a way that you can also combat some of the other problems by going in with not just we're just going to fix one problem, but like going into the house and trying to provide as many services as possible through an integrated delivery of services.
Okay. I think we have time for one more question, if we have one. Or maybe not. I think that wraps up our presentation for today. So I really want to thank again Ms. Scott and Dr. Diet for coming today for this great presentation, and thank you all for coming. And we hope to see you again next month on the third Wednesday for our next Grand Rounds. Okay, thank you very much.